There's the Senate Appropriations Committee. It's Thursday, January 8th. And we're going to be going through further Budget Adjustment Act recommendations from the governor. There is HS with us today. So for the record, introduce yourselves and you can start your presentation.
Great. For the record, I'm Christy McClure. I'm the Deputy Secretary of the Agency of Human Services.
And for the record, I am Tracy O'Connell. I'm the Chief Financial Officer for the Agency of Human Services.
Thanks for being here.
And as I mentioned, the Secretary sends her regrets. She would like to be here, but she is on vacation with her family and she'll be back next week. So in the meantime, I will take you through the overview and Tracy will go into a little more detail. And as you know, the departments will be in here providing even more detail. So for the Agency of Human Services, just as a reminder, it's comprised of the Secretary's Office, which includes healthcare reform, and 6 departments. Those 6 departments include DALE, which is the Department for Disabilities, Aging, and Independent Living. DCF, which is the Department for Children and Families. DOC, Department of Corrections. VDH, which is the Vermont Department of Health. And DEVA, which we actually call DEVA, is Department for Vermont Health Access. And DMH, Department for Mental Health. You may hear in some of the commissioners' testimony a reference to the HS Executive Leadership Team. So that's comprised of 6 commissioners, the Secretary, the Deputy Secretary, and the Medicaid Director. So collectively, as we've gone through this process, the Executive Leadership Team has been the table for the BAA discussions and budget discussions. So, as a reminder, for state fiscal year 26 budget, it was $5.8 billion across all funds. Of that, it was $1.4 billion for general fund. And for the BAA request, it's $33.2 million for the general fund. So again, I'll go through the broad brush strokes of this. So of that 33 million, we have about 50 million in pressures and about 16.3 that offset that to get to that 33. The pressures include caseload utilization, required rate adjustments, contractual agreement, and other operating items that Trace will take us through. The savings and offset are from revenue and caseload utilization. So I'm going to hand it over to Tracy.
Okay, thank you. And again, I will give an overview of the different areas of pressures that we're seeing, but each of the AHS departments will be able to speak to those individual pressures more specifically. So in the space of caseload and utilization, we are seeking $23.2 million general fund and budget adjustment. The primary drivers of this is DEVA, Medicaid consensus, and also the clawback payments to the federal government. In the Department of Mental Health, we're seeing caseload and utilization pressures at the private non-medical institutions. And in DCF, there are some caseload and utilization pressures in the sub-adoption and general assistance support services area. Support services covers burials, dental, and abortions. And then in DALE, choices for care, we have some bed day utilization pressures. And then finally in DOC, we had a trip to send incarcerated individuals out of state back in November. So those beds were not budgeted for, so we're asking for an adjustment there. Now we are also seeking $6.6 million general fund for required rate adjustments. For DEVA, the Medicare Economic Index, that is required for us to align rates for the federally qualified health centers and the rural health centers. Reflects about a 2.7% increase in their rates. And then for DALE, choices for care, extraordinary financial relief, and also for the Vermont Veterans Home Settlement.
Can I ask a question about that?
Sure.
Is that the normal cost and settlement that we do with the veterans home, but that we were going to switch it?
Oh yeah, great question. So yes, we did try to build that into the base. We built on a gross level, we built 3.9 million into the base in 26. But after the state fiscal year 24 costs were settled, we still need about 963,000 gross.
And are we assuming that wouldn't happen next year, or it could?
Possibly
No.
could,
Okay.
right? Mhm.
That's something.
Mhm. Okay. Now on to contractual agreements. We're seeking $14.8 million general fund for some pressures on contracts related to DIVA, the MMIS contract with Gainwell, and the DIVA Medicaid Data Warehouse Analytics Solution, also known as MDWAS, with Deloitte. We're seeing some transportation pressures at both DCF and DMH, as well as DMH travel nurses and forensic, an increase in forensic evaluations. And then at DCF, we've recently signed a contract for a provider to provide services at the Wyndham County Sheriff's Office facility for crisis stabilization beds. And then for DOC, the WellPath contract, we are seeking an increase due to an increase in the average daily population. When the contract was originally negotiated, it assumed an average daily population of 1,250, and right now the current level is at 1,500. So we had to renegotiate that contract.
On the traveling nurses, and I can ask Commissioner Oz, but why was it miscalculated? Was there a change in personnel that required more travel nurses, or more just case pressure?
I believe the commissioner will be able to speak more, but my understanding is because of ongoing vacancies within the department.
That they thought they were going to fill, weren't able to.
Correct. And that the value of that adjustment is $386,000. Okay, moving on to other and operating, $4.8 million general fund request. 109,000 is related to the Pilgrim Park lease for DIVA for more space, for more office space for the return to office. And then for DIVA and BDH, the Planned Parenthood Medicaid backfill with HR1, there is currently a 1-year prohibition on drawing down Medicaid for the Planned Parenthood provider. So we're seeking a backfill for that. DCF income verification system, the federally provided system is no longer available. So DCF needs to procure a new vendor. That's about $50,000. And then related to the HOP shelter expansion investments, we stood those up with one-time startup funds, but now the operating costs for some of those shelters, we need a $2 million adjustment.
And then you go over the DOC utility?
Nope. And then lastly, DOC utilities that were not budgeted. That is $100,000, and then some staffing supports associated with DOC, $285,000.
What does that mean, non-budgeted utility?
Maybe the commissioner will be able to, to speak more, but my understanding there was an agreement down in Springfield for a utility.
I believe it's water, but again, Commissioner.
Yeah. Mhm.
Seems like something you would normally budget. So, yeah. Fine. And on the Pilgrim Park lease, I assume that's just what you need to finish. Since it's a new lease, it's just for this fiscal year. So this is the return to office
Yes.
kind of need, right?
Correct. This is a prorated amount for the lease that we signed back, or that the administration signed back in December.
So they'll carry you through this fiscal year, and in your budget, they're either requested.
Correct. Mhm. Okay. We do have a few areas where there are some savings. One is with in global commitment, we receive 90% federal matching percentage for the childless new adult group. And so their utilization is higher, so we don't have to match it at the normal FMAP rate. So that actually is a savings for us. And then we also had some general fund carry forward from the end of last year that is able to reduce our request. And then for DOC, we have a global commitment investment called Community Rehabilitative Care. This is where we can claim Medicaid for some of the case management for the probation and parole officers. And so we're seeing an increase in their time that can be allocated for Medicaid. So this is a good thing. And then we have a variety of savings in the DIVA buy-in caseload and also some other DCF caseloads such as AABD, essential persons, and reject. Okay. We do have a few one-time requests in the budget adjustment. One is the return to office fit-up costs for both for Waterbury and Pilgrim Park, $385,000. This is to help purchase desks, chairs, conference room technology and furniture, and partitions. And then for Vermont Health Connect, we need to move the vendor over to a cloud-based system. Right now it's on the servers, and we must move over to the cloud in order to maintain the connection to the Federal Data Services Hub for real-time eligibility. Steve can speak more detail about that. We also are seeking a one-time adjustment for the Brattleboro Retreat alternative payment model that we have. We are currently budgeted at 20,440 bed days, but we're seeing an increase in the number of bed days actually used. And this is the amount over the corridor that we are responsible for paying.
This came up in Commissioner Gresham's walkthrough. It was unclear if the payment, you had to, when you got over the certain amount of bed days, you just had like one large new payment, or was it somehow prorated over those bed days?
Yes, it's prorated. Even could speak to that, but yeah, it's above the known corridor. That then we
They made it look like you get one bed day more and you got to pay $7 million.
no. The current estimate is 3,000 beds over right now.
Okay.
And then lastly, $150,000 for an upgrade to the DCF child abuse hotline in order for it to be compatible with the server requirements. And so that concludes our overview.
And you know how this compares to other years, like this 30 million or 33 million of general fund. I mean, we have such a large budget.
Yeah.
33 million seems like a big number, but you're over $1 billion.
Yeah, it represents 2.35% over, and it was comparable to what we had requested previously. Mhm.
Kind of normal.
And really, some of the, like, for example, Medicaid, the pressures are related to what you saw at closeout. And we had a few areas of savings, one-time savings, and a few spaces that were able to cover that in the last year.
Thanks.
Did you want to go through the ups and downs of the particulars for the secretary's office?
I don't think so. People, unless there's something that you want to highlight.
No, just one reoccurring adjustment you would see is in for the ADS service level agreement. We had budgeted what we were projecting to be the increase for 26 in the secretary's office. And now that we've gotten the final bill, we know where to parse it out to the department. So these are, you'll see net neutral transfers for the ADS service level agreement. It's not an increase, it's just putting it in the right spot.
You know which section on the big worksheet that Gresham hands out, like which is it B312 or where that is on the sheet?
B300.
Well, so all B3.
Yeah, we're
for the
moving it from B300 to all of really the administrative appropriations within the AHS departments.
But the secretary's office, yeah, is B3.
Correct.
I don't think so. I don't think we need to go through the ups and downs.
Okay.
I mean, we know the general
Yeah.
situation.
Yeah. The bulk of the request is actually in the 301, which is the global commitment appropriation. Just as a reminder, this is what is referred to as the mixing bowl for Medicaid. It includes both the state match and the federal match that help pay for global commitment. So out of all the previous requests I described, anything associated with Medicaid, the general fund is appropriated in 301. And so out of the 32 million we're requesting, 17 million general fund is in B301 associated with Medicaid.
Yeah, we might have questions for the commissioners. I know there were some questions about the relief funds for the nursing homes, things like that. We can get into that later. Okay, thank you. I saw Commissioner Hans come in. How are you?
Good, how are you?
Great, thank you for coming.
You bet. You unfortunately just had me today. The DMH does not have a finance director, so I'm
Wow.
sure that Tracy
I will be your phone. Sure.
will be my phone a friend if we need that. Sure.
Well, sounds like a vacancy state.
This is true, for now. And if you don't mind, I'll just join it.
Yeah. You've had it. Okay, but your handout was like your system of health, system of care.
That's correct.
But you must also have something in.
Yes, it's in the larger worksheet.
Yeah.
And I can give you. It's B 314 under the DMH. Let's start off
Okay,
there.
yeah. Okay. When you're ready, you can introduce yourself for the record and.
Get up to date. What's happening, people there. Takes that money, it's the woman who sits for this to the right of the three of them. But normally, the one who sits closest to you. The bonus, yeah, Aaron, Aaron, okay. His own paper badge. Or we set up a Venmo. And he actually.
Who doesn't have them?
I know, really.
Our medical director didn't have them when she was looking for something.
And
And you changed them, you or I haven't
I
done.
got direct pipeline to my daughter.
Did you just say that?
I did.
All of that free time.
Venmo?
I
Yeah,
like
you
it.
know I do. Oh my God. Just barely.
It's getting better.
Did you have one used to go?
Yeah.
You have
It's
that kind of thing?
Wednesday.
Yeah, that was the
It's
thing.
from bank
It
to
just-
bank. So it's
Did you have that kind of
way,
thing?
way better.
Fairs for this?
Plus, I think. those-
No, I just
Elon
don't check or
Musk-
something. I just barely started with Venmo.
Okay,
Wasn't
people pay
PayPal
when they're
Elon
buying
Musk steal?
stuff from your
Credit card.
I have no idea, but, the Venmo piece is from bank to bank, so it's a lot safer. Yeah. I remember the days when I was sending money by Western
Although-
Union. They would charge you like 15% for sending.
Was that by the Pony Express?
It was like the first electronic transfer. Actually.
You had to deal with it at the grocery store.
Actually, the best way to send money out of the country still is Western Union. Oh, yeah.
Really?
Why do you send money?
It's still in-
Yeah, I know. You should have to miss a beneficiary. Talk more about it.
Did it come through? Oh. It's just taking a while. I should know.
Yeah, we heard that.
Yeah,
No, I'm just looking.
well,
for that.
Western Union.
Were you looking for it?
Oh,
I'm
my
ready.
debit card, it's $2 and then.
Today, but that's okay. I know what our system looks like.
Their website.
Yeah. Yeah, I know what our site is like.
So we have one slide.
That is our system of care, which I should be rather familiar
You
with.
can
by
look
now.
up there and.
So I'll go ahead and get started.
Okay.
For the record, Emily Haas, Commissioner for the Department of Mental Health. Thank you, for having me today to talk about our DAA, FY fits. So I thought I'd start out with just a brief overview of the current, system of mental health. And so as you'll see by, this slide, the foundation of our community mental health system is here at the bottom. And without those community mental health supports, the rest of the pyramid doesn't exist. And so down here at the bottom, we have our micro residential programs, which are for youth We have youth group homes, otherwise known as a PNMI, and we'll talk a little bit about that as we get through our ups and downs. We have adult group residential homes. DMH also holds a variety of shelter plus care vouchers for individuals. And then all of our traditional individual family-based outpatient services. The next level up is our crisis response components, which include crisis stabilization programs, which and also youth hospital diversion. It also includes adult integrated care beds, which are crisis beds that can serve individuals experiencing both the mental health and substance use challenge. We also have mental health urgent cares across our state, which this group has worked with us on. 988 Crisis Lifeline, which is the 24/7 crisis line that folks can talk, chat, text. It also includes our mobile crisis response. It's a 2-person response in the community across the age span, serving individuals with both mental health and substance use service needs and then crisis supports. The next level up is our intensive residential programs. So that's examples of those are our youth residential programs, intensive recovery residential for adults, peer run residentials, and then coming online in the next year is our youth psychiatric residential treatment facility, which will be at the Bradford Tree. And typically
Is that the one that we had trouble citing? Or is that something different?
Southwestern Vermont Medical Center is an inpatient, adolescent inpatient unit, which is not on here yet because it's a little bit further out. But that was a project that we did a lot of testimony on.
There's also, isn't there a secure residential facility that's being attempting to be?
That's what I was.
Oh, that's under DCF, so
Yeah.
you'll hear more from them about that. That's the Woodside
Right.
replacement.
Yeah.
Yeah, that falls under the DCF budget. We do have a secure residential for adults. That's the River Valley Therapeutic Residence in Essex. That's that next level of residential. And then
Beds are there?
there are 16 beds there.
But that's not for anyone who's been judicially involved. That's not for someone who's been convicted of a major crime.
They could be, that it's based on the treatment need. And so somebody's forensic status doesn't equate whether or not they need that particular level of care.
So then we could say then that we have a forensic facility for those.
We would not say that.
Okay.
It's just a forensic facility that we have up by Central Vermont.
The state of Vermont does not currently have a forensic facility. So next to Central Vermont Medical Center is a 25-bed adult inpatient hospital, and that's for adults who are under the care and custody of the Commissioner of DMH. Folks there can be involved in the criminal justice system. They can be there for competency evaluations and such, but there's also individuals there who are not. So again, access.
Do you call it a secure facility? What do you call it?
It's a hospital.
Okay.
Yeah, it's an inpatient psychiatric facility. Access to it requires an individual to need hospital level of care as defined by CMS. And admitting physician determines that an admission there is required based on that individual's medical needs. It also, the folks need to be under an involuntary status. So you can't, for lack of better terms, just go check yourself in.
Or out.
Or out without going through a particular process. Yeah. We also have inpatient hospital beds down at the Brattleboro Retreat, serving both youth, adolescent, and adults. And then, like I said, BPCH is a level 1 hospital, which that language or definition was put into play in our system after Tropical Storm Harvey to define those individuals who might need more resources in order to appropriately serve their clinical needs. And then we also have inpatient units at Rutland Regional Medical Center. And then folks can also access inpatient hospitalization at UVMMC, at Wyndham Center. And then we also collaborate with the VA for some adult veterans and veterans. And that is a snapshot of our mental health system.
I have a question for you. So
Sure.
level one is at the top of the pyramid,
It is.
the acute care.
Mhm.
And if you look at recovery residences, it's just the opposite. It would be level 5. Or 4. So I'm wondering, is there a way that we can,
From the ASAM criteria
Yeah.
and how they define
Yeah.
the recovery residents.
Yeah.
Yeah, they use two different models to define that level of
because
care.
when you get co-occurring, it makes it confusing. That's
It
all.
does,
Yeah.
it does, yes.
You might need a level 1 and a level 5 and
There are individuals who come to say the Vermont Psychiatric Care Hospital who are co-occurring. But they are there because they have a major mental illness that needs psychiatry to serve. They get stabilized and then discharged and require some follow-up substance use services from the broader substance use system. But they do use two different approaches to determining that level of care. Great. So I'll move on to the ups and downs sheet if that works for you all.
So I don't know if I saw your down sheet. We have a big sheet.
Or is
It's a,
it part of this?
It is, it's part of the larger, I don't know,
Page 10.
Page 10.
page 10.
it's not on this.
You might have to scroll to the top.
Oh, what's part of this? I see. It's just not on either.
If you want to try this. This is more field for me. That's already 10 weeks.
And you bring in one better.
Yeah, yeah. Sorry, we took a sidebar. Are we set?
Yeah.
Okay. So you'll see this is a fairly small number of items. I'll start with personal services. We experienced an increase in transportation cost for both youth and adults. These are transports related to inpatient hospitalization, also out of state placements if a youth is traveling out of state, folks waiting in emergency rooms to the next appropriate level of care. We've seen a gradual increase in transports for a variety of reasons. One, there's more people presenting for needing care. And also we are experiencing less family members' ability to do transportation.
Who do you use to do this?
Sure. Use a couple of folks, our sheriffs. We have a contract with the sheriffs, and then we also have a private contract with a company called YTA, Youth Transport Authority, although they transport across the age span.
Do you need somebody like a sheriff to make these transports, or could it be?
It could be anyone. We're required to transport folks in the least restrictive. And so we want to make sure that we have a variety of options. We use a sheriff only when we really need to.
And this is like different driver or.
Mhm. Yep,
So it
or
could be a-
BBCH.
it could be a long
or-
list.
Yep, could be a few buses. The next line item is for forensic evaluations. For this group to know, forensic evaluations are evaluations for individuals that are ordered by the court because their ability or competency to stand trial is in question. So the court orders those, we've seen an increase in the number of competency evaluations that have been ordered. And so that has gone above what we were originally allocated. The next line item you'll see is a net neutral transfer of 51,284. That's the internal service fund to cover for ADS services. So that goes to AHS central office.
Center lines.
I just want to go back to the increased cost for the forensic evaluations for competency. And
Yes.
what is what is causing that? I know it's the number of evaluations, but is it ongoing evaluations for one individual, or is it multiple individuals coming in and increasing the load overall? Or is there a timing piece to this?
Yes, that's a great question. So for the most part, folks are receive one competency evaluation. And unless they have multiple crimes and the court hasn't combined all of those together. So it depends, it could depend. For the most part, it's that more individuals are being ordered for a competency evaluation. Historically, individuals ordered for such evaluations were individuals experiencing a serious mental illness, for example, schizophrenia. We are seeing orders for competency evaluations have expanded past that group in the last several years to include individuals with TBI, dementia, substance use disorders, individuals that don't necessarily fall into the category of a serious mental illness.
And yes, no,
Mr. Chair, can I ask a question?
sure, you may.
On the transportation, the increased costs, you have a up of 320, but a down of 150 global commitment. Are you just switching, just that you adding different funds? Or is it increased cost because it's more general fund, or is it increased utilization?
Let me check my notes. Increase in utilization.
So I'm going to be down as well.
In addition, there's more adults also who don't meet the definition of serious mental illness needing transportation.
Okay, covered. Thank you.
If there's more though information that you need,
I'll go to Tracy.
thank you.
That's you.
Next is our federal grants. So our federal revenue reconciliation, this is also an AHS net neutral. And then the PNMI increase, and the PNMI increase relates to those 24/7 facilities, both in state and out of state. So we certainly don't have a lot of control around rates for out of state placement. And if a youth needs a certain level of care that's not offered in Vermont, if you get out of state. But we have seen a use increase in the use of PNMI as well as a rate increase.
Go ahead.
Okay. Next we'll shift to section B 315. This is the section that's directly related to the two facilities that VMH runs, Vermont Psychiatric Care Hospital and River Valley Therapeutic Residence. And so you'll see in the first line, the GF swap for GC, the Medicaid billings at VPCH saw a decrease this last year. We were unable to capture as much as we had anticipated from a billing perspective. The next is VPCH special fund revenue reduction.
and not turnover saving, vacancy saving?
We do have vacancy savings, as the next. It looks like they forgot to take out that one line. So, vacancy turnover savings is, up next. That's a 4,549,000.
And how does that compare to other? It seems like a large number, but I'm.
Yes.
44.
And so we've separated out the vacancy savings with the travel nurse contract, so folks can compare the amount that we're spending on travel nurses. Which we
Right.
should do, and the overall vacancy savings, for the hospital. So we were over by, quite a bit from a travel nurse contract perspective. And our vacancy savings didn't match that.
Just because it's hard to hire these type of nurses.
It is challenging to hire. We are seeing improved hiring as of the last quarter. But we rely heavily on travelers to run the facility. We have less travelers now than we did a year ago, and even more so a year from there. So things are improving just at a very slow rate. We're also working with our contractors to decrease the hourly rate that we had been paying. We've gone from the initial spike that happened during COVID to coming down every year since then, so that we can come into a more reasonable contract.
And nationally, is that bearing out?
Like coming down from the use of
Yeah.
travelers.
Or the delta between what they get paid as a traveler and what they get paid at this state.
It depends. We are seeing some leveling out of the use of travelers nationally. For VPCH, it also acts as one of our primary opportunities to recruit. And so we often have a traveler start, and then we talk them into applying for a permanent position, and they make that switch.
I've met a couple of nurses that came to Vermont as travelers in the state.
Yeah, and that works really well for us because they already have a place to live. And they already know the facility and some orientation and it's costly. They're already providing service, but there are some hospitals that refuse to contract travelers in other states, but we want to make sure we have as many beds as possible. So it's not that. And then the next line down is the cost of room and board at River Valley Therapeutic Residence, and that is a line item to support dollars that are not Medicaid reimbursable for room and board for residents that are staying at the facility.
Right. That's all your, right?
That is it.
How can we get rid of travelers?
You can train after years.
I know.
Well, how long have you been there?
I've been in this position for 4.5 years, commissioner,
So that's
and then I ran VPCH for 4 years before that. Yeah.
So like then that 8 years, was there a time when travelers were a very small part?
Yes, we had around 14 or 15 travelers pre-pandemic,
And now how many?
47.
Hmm.
So it's really shifted.
And have we made progress by offering better pay?
Yeah, we've gone through, we've moved to 12-hour shifts, which was helpful for folks to manage their work-life balance. We've worked with HR around shift differential improvements for pay through that way. We're also working with the talent acquisition folks with HR to be able to hire into range for new staff coming in. Although if you're an existing state employee, you don't have the options of a hire to range if you're taking an internal position. VPCH shares the same contract as the rest of state government from a collective bargaining agreement.
So have you had an issue where you wanted to bring in a nurse into range, but then that would affect all the other nurses of that class.
Yep, and we've addressed that. Where we run into an issue is if an internal candidate wants to move into a higher position, but we're not able to offer them a higher step. They don't have that negotiation if we're hiring internal.
Any other questions, Commissioner Hodges? Right. Thank you.
Thank you.
Thanks for your work. Important work for the state.
Yes.
Yeah, Commissioner.
No, it should be here. They might be in the last one. You'd like to check.
Sure.